Thank you so much, Dr. Lang, and thank you for the organizers for the invite. I'm really excited about talking with you today about the systemic therapy of metastatic brain tumors, and really appreciate my colleagues highlighting the role of surgery and radiation, and also the partnership with Dr. Lang in kind of bringing a true multidisciplinary interdisciplinary care to those patients. I will try to speak a little fast to make up some of the time just so that we can go over stuff, but I'll be happy to answer questions along the way if needed. But simply let me start by telling you again, as you've heard from Dr. Lang, that melanoma is the disease that goes to the brain the most, and I am a melanoma doctor in my regular clinic outside of the brain metastases clinic, and that's where we've seen the most progress. And really like to show this particular study from Dr. Davis, our colleague here at MD Anderson, who published in 2011, only 10 years ago, the fact that patients with melanoma brain metastases have dismal survival, and the only 20% of them are alive at 1 year. And in the last 10 years, we've seen major progress in melanoma. We've had 12 drugs that are currently FDA approved. Our overall survival has gone from less than 5% at 5 years to actually now 50% at 5 years. In fact, we just saw data that I'll show you briefly here at ASCO, where Ipi-Nivo has shown a 6-year median overall survival, which is, again, unprecedented, and shows us that we are kind of hitting a situation where we're giving cures to our patients with melanoma. And this is also true for a situation where we're looking not only at the overall survival, but even melanoma-specific survival. We're almost curing close to 60% of our patients. We also saw at this ASCO the really exciting results of relativity, which is bringing new therapies to melanoma. This is nivo and relatlimab that is likely to become FDA approved as well. So with now 13 potential approvals, I usually summarize all of the pivotal trials that have led to these outcomes, and these are all of the phase 3 registration trials. Just updated it this morning with relativity at 700 patients. So close to 8,000 patients, and not a single one of those patients is allowed on study if they have brain metastases. And I give this as an example. This is one of my own patients that came in with a large axillary mass with multiple subcutaneous lesions, an adrenal lesion, bone mets, and truly in a lot of pain. We wanted to put her on a triplet trial with dabrafenib, trametinib, and spartalizumab. And when we did the screening MRI, she had this tiny little brain metastasis, and that was enough to exclude her from study. So it really is and was a frustrating situation, continues to be to a degree. And the question is, why are those patients excluded from trials? The usual kind of arguments that are launched against including those patients is that they have a worse prognosis, they have an immediate neurologic deterioration, those drugs really don't get into the brain, and maybe the immune system never gets into the brain as we think of the brain as an immune sanctuary. So perhaps that's why we need to go with surgery and radiation. And you've heard, as effective as they are, they still have significant limitations in terms of multiple brain tumors and disease control outside of the local area that you're targeting with either surgery or radiation. But that has started to change, and this particular image I'm showing is from the study called BREAK-MB, where we have shown in melanoma for the first time that a BRAF inhibitor, a single agent BRAF inhibitor, was able to lead to significant responses in the brain. And that led to combination therapy, so dabrafenib and trametinib in the brain. And you see here the rate of intracranial response in this study called COMBI-MB, where the rate is really high, 58%, which is really close to what we get extra outside the brain, about 65%. So with targeted therapy, we make significant, we can affect significant responses. What we've learned from the study, however, that targeted therapy actually does affect a high rate of response, but the duration of response and the disease control in the brain is actually a lot more limited than extracranial disease. So as you see here, the median PFS outside the brain is about 10.8 months. Inside the brain is exactly half. So targeted therapy helps, but doesn't help in the longer term. What about immunotherapy? So the first trial that was done was actually ipilimumab. This is with my colleague, Dr. Margolin, that showed that if patients were not on steroids at the time of therapy, they actually had overall survival curves that look just the same as those patients without brain metastases. Single agent and pembrolizumab, and there was a separate study with single agent nivolumab that showed also durable responses in the brain. However, the response rate was somewhat reduced. Outside the brain, we get about a 40% response. It was 22% in the brain. And so when we tried to kind of increase or intensify therapy, we brought ipi-nivo, and this is Checkmate 204. Outside the brain, the response rate is 57%, and we feel that's our most potent immunotherapy. And sure enough, inside the brain, even when you come in with larger lesions, and I hear a lot about these being small asymptomatic brain metastases, but this is a patient that was on Checkmate 204, and after a year of therapy has had almost a complete response to therapy. And this is not just one patient. As you can see from this waterfall plot, it was actually 57% of patients have objective responses. About 30% of them are complete responses in the brain, and the effect happens relatively quickly. The median time to response was only 6 weeks. In fact, the first time we checked, and at the time of reporting of these data, most recently published in the Journal of Neuro-Oncology as well, 87% of those responses were ongoing. And this is what the PFS curves look like, again, that we have some really significant control and a plateau after a while. The overall survival looking just as good as patients without brain metastases. However, as we did this, we also recognized that those patients were specifically asymptomatic and not on steroids. And we wanted to ask the question, what happens if those patients are symptomatic or on steroids? And we included 18 patients in this cohort B in Checkmate 204 that were symptomatic and required up to 4 milligrams of dexamethasone. And unfortunately, the response rate was only 22%. Now, when those patients did respond, the responses were durable, but we also found that most of them were not on steroids. So only 1 of 11 patients that were on steroids responded, whereas 3 out of 7 that were not on steroids did respond. When you respond, you get a good response, but a lot more limited if you're on steroids. And so we think that this is an area that is of active investigation. We really need to figure out ways to deal with decreasing the steroid use, again, potentially using surgery to get there, radiation to get there, maybe targeted therapy. The other issue that we're dealing with is actually the fact that ipi and nivo is very toxic. So we have about 55% grade 3/4 toxicity. And so we're looking at novel combinations to increase the efficacy and decrease the toxicity. So we have a trial here at MD Anderson with using low dose ipi and pembro or triplet therapy, which I won't report the results right now, but just kind of those are 2 approaches. And very interestingly, this is our portfolio of all the clinical trials that we have for specifically just melanoma brain metastases. And as you see, we kind of think about those immunotherapy naive patients that are asymptomatic. We're really excited to start the study of nivo or relatlimab very soon. I'm actually writing the protocol right now. But also, if they come with PD-1 refractory disease, we want to try to reverse that with targeted therapy, with MEK inhibitors in combination with Avastin and PD-L1 in a study that we call TACO, and then the AMD Sorona study, which I'll talk about in a second. So this is where we stand with this particular situation. There's a big question about how to incorporate SRS, and we're working very closely with our radiation oncology colleagues, including Jing Li, to actually figure out when to specifically include SRS and whether we should treat at the first time of restaging. But I won't go into that. It's a bit complicated. I'm happy to talk about it. The other thing is, can we have immunotherapy outcomes or systemic therapy outcomes beyond melanoma? And I'll talk briefly about RCC, lung and breast. And so as you know, PD-1 antibodies are already approved in renal cell carcinoma, and this is a study that had about 39 patients that were included with single agent nivolumab that were untreated brain metastases, and they actually had intracranial responses, as you see in cohort A. It was about 14%, but shows that also you can get intracranial durable responses. The combination of ipi and nivo was looked at by BMS in a small cohort in a study as well that used what we call flip dose, so low dose ipi and high dose nivo, and they reported a 28% disease control rate and a median PFS of 9 months and a median OS that had not been reached. So even in renal cell, we have evidence of response with immunotherapy, and we're kind of building on that. when you think about diseases like breast cancer, we know that not all breast cancer is the same. We know that two populations are particularly important. The triple negative breast cancer and HER2 positive breast cancer both have about a 4 times higher risk of metastases in the brain. And interestingly enough, we're kind of now entering an era where new drugs are being developed with the idea of getting into the brain. And tucatinib is a great example. It was designed so that it has an penetration into the brain, designed so that it actually crosses both itself and its active metabolite into the brain. And in fact, in a phase 1 trial that was led by Rashmi Murthy here at MD Anderson, showed that the triplet of tucatinib, capecitabine, and trastuzumab had a really impressive intracranial response of 42%. This led to the HER2 CLIMB study, which is a remarkable trial. It was the first randomized breast cancer trial to actually include, by inclusion criteria as opposed to exclusion, untreated brain metastases not needing immediate local therapy. And sure enough, the triplet was more effective. By PFS, the hazard ratio was 0.54. By OS, the hazard ratio was 0.66. But then if you take the patients that actually had brain metastases, that's where most of the benefit was. And the hazard ratio was 0.48. So this drug being able to get into the brain is probably what made it so much more effective and led to FDA approval, which I think is remarkable in a lot of ways. And this was also in the New England Journal of Medicine. And Rashmi Murthy is one of our breast cancer doctors in the brain metastases clinic at MD Anderson. So you heard from Dr. Lee, this is the very talented group of surgeons, radiation oncologists, medical oncologists, neuro-oncologists, neuroradiologists that are all helping us figure out how to treat those patients in the setting of the brain metastases clinic. You heard how important this is to us as kind of a hub of clinical research. So I just want to show you a couple of trials that we're doing and end with some of the translational work that we're interested in. So this is one of the studies that was actually developed because we have a brain metastases clinic, because we have access to lung, breast, and melanoma. We felt that treating patients with a brain penetrant MEK inhibitor with an immunotherapeutic agent that is a bispecific to PD-L1 and TGF-beta, both mechanisms of resistance to immunotherapy, that would be applicable to patients from all 3 diseases. And in fact, we've just recruited our 3rd patient just this week to this trial. And the fact that we have this study has actually helped some of our investigators, like Dr. Wang from the GU Medical Oncology Group, actually got funding to study the role of ipi/nivo in addition to, or with the addition of cabozantinib to ipi and nivo in patients with renal cell. Dr. O'Brien is running a trial specifically for patients with MET alterations. We have 2 studies that are exploiting pembrolizumab with lenvatinib, and the other one is tucatinib and trastuzumab, TDM1 in patients with breast cancer. So multiple approaches to systemic therapy that are being developed because we have a brain metastases clinic. And the last thing I'll leave you with is we're really interested in mechanism and kind of how does this stuff work anyway? And really remarkably, in some preclinical models, ipi and nivo was not supposed to work if you don't have disease outside the brain, while in our clinical management, we actually found that it does work if you don't have disease outside the brain. So the question of whether you actually activate the immune system extracranially and the T cells get into the brain or not is actually not answered. So we have some moonshot funding at MD Anderson through something we call the FIT proposal to actually study that. So we look at a surgical specimen similar to what Dr. Lang discussed about the Catalyst program, taking those tumors right from the OR and trying to understand what is happening with them in terms of the drugs getting into the brain, in terms of the immune microenvironment. And we're also working very closely with our colleagues in Traction, as it's a platform here to run preclinical models at an industrial scale, to actually run preclinical models with implanted, with intracranial tumors so that we can screen different drugs and decide which ones should graduate to be clinical trials in the brain metastases clinic. So I hope I kind of managed to give you a sense of how we've shown that targeted immunotherapy can be safe, can be effective. We have to not only increase efficacy, but think about decreasing toxicity. And the fact that our clinical care is multidisciplinary allows us to think about this from multiple angles, to engage our colleagues in a preclinical setting. And I really think, again, we're really excited about the role of the Brain Metastases Clinic in being a platform for new clinical trials and accelerating drug development. Really, my recommendation in general is, even if you don't have an actual clinic, I think the ability to speak between the 3 disciplines, 4 disciplines with the radiologist involved is very, very critical to our patient care, and I think will help their outcomes. And with that, I will end and thank many, many people, including people on this call, for their help and collaboration partnership around the Brain Metastases Clinic. And thank you for the opportunity.